Yes, Dr. Rooney.
All right. So for names, we recommend, Dorothy has it, perfectly, PH360 Fellow or PH360 Faculty. Please, and yeah, I see Elisha, I see Wells, Brown. Let's get that done. To do that, you just hover over your image, click the three dots, rename. So you put your name, first name, last name, and then if you're a fellow, PH360 fellow. Yes, if you have your qualifications, I like that. Ruth, thank you. What is the better day to display what you have than today? All right, so you go hover your mouse over your image. You're going to see ask to unmute, and then you're going to see three dots. Click on the three dots, and then you will have rename. And then in the rename, you update your name. If you're a fellow, PH360 fellow. If you're faculty, PH360 faculty, and so on and so forth. Thank you so much. All right. Looks like we have most people in. Some people are still coming in, but we're gonna have an interesting day. So I'm gonna really start it off by once again introducing myself. I am Dr. Rami Azuine. I am the lead faculty here at the Global Health and Education Projects. GHEP is a 501c3 organization recognized by the U.S. Internal Revenue Service. Our mission is to eliminate health disparities by addressing the non-medical factors that impact health outcomes. These non-medical health outcomes are called the social determinants of health, SDOH. So we are so glad to be hosting the Public Health 360 program, which is our opportunity to contribute to our mission to eliminate health disparities by training the next generation of public health professionals from across the world who will go on to change the world, who will go on to eliminate health disparities, who will go on to become leaders in different public health roles, be they in clinical roles, be they in community health, be they in international organizations, health departments, federal health agencies, ministries. We are hoping that each and every one of you will become ambassadors of this program. So I am really excited. Today is one of the days that I get the most excitement. And just to confirm here, we have this program going on live on Facebook, on YouTube, and so on and so forth. So please feel free to to blog, to tag people when you are on, and just make sure that you can let your community join us. Your community being your friends, being your family, being significant others, and so on and so forth. So today I am excited. We have 4 groups. Each of these fellows have, over the last 3 months, invested their time, sweat, energy, sleepless nights, waking up in the night, waking up in the morning, really, really contributing and sacrificing all their pleasure in order to get to this position. And like I always tell you, if these were to be easy, there will be over 1 million people doing this program. So the fact that we have less than 30 people admitted in this program who completed this program is really a testament to your resilience, a testament to your greatness, a testament to the thing that you are going to do in front. So let me just test you again. Use your reaction button and give me the symbol that shows how you are feeling today. I'm feeling great. I'm feeling celebratory. I'm feeling, what is it that you're feeling? Like you can see me, I'm feeling ta-da, right? Use the sign and let me know what you are feeling. Go ahead, do it. I was trying to get my second monitor so I can see everybody's face as we continue. Next slide, please, Brown. All right, here are our faculty. You have met them before. We have myself. Once again, we have Dr. Susan, Dr. Nzube, Dr. Chudubem, and Mr. Brown, who have really worked with you closely over the last 3 months to get you to where you are. So we are really, truly grateful for giving us the opportunity to come to your professional lives, giving us the opportunity to come to know you. Just remember that what happens once you graduate today, it does not mean that is it. You automatically become welcomed into the family of PH360 alumni who are spread across the world. I think we should have now more than 100 people who belong to this small group. We are still in the process of thinking, how do we create this community? A number of ideas. Last cohort gave an idea for us to do a public health conference somewhere in Africa, in Asia, or here in the United States or Canada. That appeal has come up again. I have an open offer from a collaborator in Malaysia who is actually asking us to come to Malaysia. So we welcome the next steps, which is to create what looks like a group. And then from that group, we should be able to have opportunities to, to interact. Part of what lies in the horizon again is how do we implement the programs that we have conceptualized over these years? More about that, maybe we can try to find out what looks like notes, according to Dr. Susan, from across the world. And then using those notes, we can implement the programs that we have done over the years. Excellent programs that we can look. So please, if there are communication from Zube or from any other member of our group, please, respond to those communication, join the group, and hopefully we can do greater things. All right. That's us again. We are here. We continue to support you. We continue to be your colleagues. If there are letters of recommendation that you need, please reach out to Dr. Zubi and copy me. I'm usually very good, but Zubi is actually almost like a task master, ensuring that I get these things done. If people want to talk to us, I love talking to employers. I love talking to graduate programs. I love talking to other individuals about the work that you have done here. As you guys have done this program, I have taken note of who did what, how you handled conflict, how you handled the collaboration, how you initiated the leadership. So we will be here to ensure that all your success are chronicled and that your next step of your career is really thriving. Brown, anything I'm missing before we go to the presentations?
No, Dr. Romy, just for able to see the programs, what this is the flow, right? What we expect. So we're on time. So that should be all. The fellows will introduce themselves while they're doing the presentation. Yeah.
Thank you so much, Brian, always for keeping me really on target. So once again, I just want to clarify your projects that you participated in. If we have any opportunities to present these projects, we will invite you, right? And then based on that invitation, we will decide. If we do not hear from you, then that means there isn't an interest and we will move forward, because we have gotten a lot of requests, from organizations, from individuals, even asking us to use these projects as continuing education opportunities. And so we are going to try that. We're going to test drive that. We're just trying to make sure we have the platform that can issue people with certificates of participation, which we do not have right now. So if you know any of those, let us know. But we'll invite you, regardless of your group, and we hope you will respond to us. All right, so let me give our faculty opportunity to introduce themselves again, beginning with Brown. Brown, go ahead.
Okay, Dr. Omi. So my name is Brown Magnus. I'm a computer scientist by profession, and I work as a database administrator. With GHEP, I work as a outreach and IT coordinator, and I've been partnering with this fellow for the last 3 months, and I'm excited for today. Thank you so much.
So just to put on record, I have only 1, 2, 3, 4, 5 people, 6, 7, 8 who told me how they feel. That means the other people feel really awful for this afternoon. Is that my read of that, or am I making assumptions? I just want to be scientific like you guys, but that's, I on record here, I have Zotile, I have Dr. Emeka, I have Benedict, I have Saida, I have yes again, I have Gostina. And then the other people said, look, this is an awful day. That's okay, just to put it on record, look, I want to be factual. I don't want to be assuming. So is that the correct assumption that people feel really? Not really, sir. Coyote said that he's excited. Finally, we smoked that Coyote out. So Coyote is not talking. Elisha finally is talking. Thumbs up. Okay. Oh, okay. I was really getting a little bit depressed because I was all pumped up this morning, but I was getting kind of depressed. Rahina is here. Rahina says she's excited. Okay, all right, okay. Gabriel is also excited. So all right, so I think we can start the event now. Even Vikash is also excited. So we can start. So all right. Finally. All right. Okay, Dr. Zubi is ready to introduce herself.
Awesome. Welcome, everyone. I'm so proud of each and every one of you today. I'm really excited. I think this is one of the best part of this fellowship because not so many people will make it to the end, but you guys really did. You put in the work, you did it, and you are here today. I'm very, very excited to see each and every one of you. My name is Dr. Zubi. I'm the Assistant Fellowship Manager. My job here is to make sure that you have a smooth experience. Everything you need, we are all here to support you. And GHEP and this Public Health 360 is one, if not the best, program that you really will get all of the skills that you need to go and make a difference out there. And you are not alone. Always remember, here is your community. You can always reach out to us. And I'm so excited and pumped to hear every of your project today. I mean, you did a lot of work. So I'm so excited to hear each and every one of you today about your projects. And yeah, thank you and welcome everyone.
Thank you so much, Dr. Zubi. Dr. Susan, I'm not sure if she's on, but she is running around for an Africa Day celebration here in Maryland. We'll introduce her when she comes, as well as Dr. Chidubem. Great. Okay, look at people I'm seeing today. Rosemary is on video today. Isn't that a great day? Can you imagine that? She is on video smiling. Oh, all the way from South Africa. This is amazing. All right. Good. Good. Kelly, I know you're not feeling well. Adjust your video. I want to see your face as you smile. Fantastic. Zotile, thank you for bringing a guest. Tell the guests that they are really welcome to this occasion. All right. Okay. So as we get into the presentations, please use your chat again and tell me, are you ready? Tell me, are you ready? If you're ready, tell me, yes, I'm ready. Let's see. Let's see who is ready to go. Layla is, right? Oh my goodness. You guys are ready? Okay. Okay. All right. Anila is ready. Some people are not sure. Zatila is ready. Gabriel is ready. Benedict is okay. Most people are ready. So couple people are not sure on the line, thinking, I don't know if I'm really ready, but I think you guys are ready. Okay. All right. So let us keep it going. For our presentations today, please, I want to be able to be clear about what the problem statement is, right? What is the problem that you are seeking to solve? I believe that each of these programs that you are going to present today is seeking to solve a pressing global health issue. And I would really love to see how the presentation goes, how you're able to articulate that work. And again, remember the rule, you will have 15 minutes of presentation, right? And then we'll have 5 minutes to ask you questions and answers. And as the moderator of today, I have the special privilege of calling who I want to answer the question from the group. And then we can open it up also to our guests, our other individuals who are in the program to ask their questions. So 15 minutes, Brown is going to give a note when your 5 minutes is, when you have 5 minutes remaining, and then we're going to really stop it at 15 minutes. And then after 15 minutes, we're going to take questions. So remember, the goal of the presentation is to give us a teaser, right? It's not going to tell us everything, but give us sufficient information for us to make a decision whether we are going to give you the $200,000 or not. Right? So, group number one, I am going to shut up now, and then we're going to let group number one tell us the problem and the program they are designing to solve. Over to you, group one.
Good morning, everyone. Under supervision of a global health and education projects, we are proposing Growth Thrive program. The team members are me, Laila Lafnan, the program director.
Hi, everyone. I am Anila George. I am the assistant program director.
Good morning, I'm Elisha McKenzie. I am the clinical director.
Good morning. My name is Vikash Salkram. I'm the Director of Outreach and Marketing.
Good morning, everyone. I'm Zotile Gumbo. I'm the Director of Strategic Partnerships. Thank you.
Through this presentation, we will discuss the following points: executive summary, problem statement, goals, objectives, methodology, theories of change, budget, evaluation, and dissemination. So let's first have a narrative review about our program. The Grow Thrive program aims to establish a community garden to foster community engagement, promote sustainable practices, and enhance food security in Forest County. The program will encourage garden participation by engaging community members through outreach, campaigns, workshops, and events. Also, partnerships with local businesses will be formed through networking efforts, educational workshops on sustainable gardening and community building, formation of community garden committee for inclusive coordination. And now let's discuss our problem statement. Food insecurity defined as limited or uncertain access to adequate food at the household level. In 2022, 12.8% of US households experienced food insecurity. Mississippi rate of food insecurity is 18.8%. On the other hand, food insecurity rate in Forest County is 21.3%, which is exceeding the state and the national level, which is equal to more than 16,000 of population. Food insecurity has impacted Forest County severely, directly and indirectly by increasing the chronic disease prevalence. In 2021, there was about 13% of people who struggle in diabetes, 40% had adult obesity, 6.6% had heart disease, and 17% had mental distress. As well as food insecurity has accelerated the mortality rate of these health issues. Between 2018 to 2022, more than 800 people died because of heart disease, and about 175 people died because of diabetes, and 48 people died because of suicide. Forest County has challenged many factors that led to increase the food insecurity issue. Some of these challenges are access barriers that is related to distance to grocery stores and need for transportation, as well as the affordability. As we know, healthy options cost more. Unfortunately, minority neighborhoods lack supermarkets and rely on cheaper, less nutritious food. As you can see on the screen, there is about 36% of Black community are struggling with food insecurity, 30% of Latino, in comparison to white population at 16%. So to make sure that we are addressing the challenges and the disparities adequately, we have formulated targeted goals and objectives. So I would like to pass the presentation over to my colleague, Anela George, to discuss that depthly.
Thank you, Leila. So I'll be discussing the goals, objectives, and the implementation plan. So the goal of our Grow Thrive program is to increase access to fresh, healthy produce and enhance community engagement and sense of belonging. Next slide. So we have main 4 objectives. By the end of the first year, the number of community members using the garden to grow their produce will have increased by 35%. Within 8 months, establish partnerships with local businesses to secure donations or discounted prices on seeds, tools, and other necessary garden supplies. And our third objective is host monthly gardening workshops and events to educate community members on sustainable gardening practices and promote social interaction. And by the end of the second year, establish a community garden committee consisting of diverse community members to coordinate garden activities and decision-making processes. Next slide. Next will be our implementation plan or methodology. Next slide. So we are focusing on community engagement strategies, which include outreach at local venues, including community centers, churches, schools. We are also focusing on garden tours, which is used to showcase community garden benefits and highlight the advantage of participating in the community garden program. And we are also planning to create partnerships with health organizations to promote growing on produce benefits and collaborate with nutritional professionals for nutrition education. Next slide. Our next step is advertisement and recruitment. We are using social media platforms to promote our Grow Thrive program, which includes engaging a diverse audience and increasing awareness. We will be distributing flyers on community meetings, events, and organizations. We are also including diverse communities in our community garden program, including diverse age groups, ethnicities, and genders, and various neighborhoods will be represented as well. The activities will be discussed by my colleague, Satila Gombo.
Thank you, Anila. Yes, I'll explain furthermore how we are going to carry out the activities of the Grow Thrive project. First of all, we are going to have the increase in community member participation in garden use. This is going to be implemented in the following manner. First of all, we are going to have targeted outreach campaigns. This is whereby we raise awareness of community garden benefits and also increase community involvement. Secondly, we are going to be hosting community meetings and information sessions. This is going to be carried out by engaging and educating community members at large. And then we also encourage the utilization of the garden to produce more growth. This is whereby we are teaching people how these community gardens are going to produce whatever they are going to be planting. Thirdly, we will provide gardening resources in the form of tools, gardening tools, seeds for planting, soil amendments, and then we also support the community members in gardening endeavors. Next slide, please. We are also going to be establishing partnerships with local businesses. In this way, we are going to have strategic partnerships. Firstly, we are going to identify local businesses. And these local businesses, we are going to have potential donors or suppliers to donate anything for the gardening projects. And we are also going to source for these donations or even discounts. We are also going to reach and negotiate with our partners to establish stronger partnerships and negotiate the terms for the donations and the discounts. We are also going to acknowledge and promote public acknowledgement of the partnerships by demonstrating community support and encourage ongoing collaborations with all the partnerships we would have created. Next slide. Then we are also going to host monthly gardening workshops and events. These workshops and events are going to be carried out in the following manner. We are going to work out a calendar of workshops on soil health so that we teach our communities what soil health is, composting, crop rotation, and pest management. We are also going to organize seed swaps, harvest festivals, and garden tours. Now, this is going to be done or led by our local experts in gardening, or should I say agriculture, such as master gardeners or extension agents. We are also going to promote social interaction and engagement among community members. Next slide. And then we are going to establish a community garden committee. Now, this is going to be established in different communities as a whole. This is going to be carried out through outreaches, whereby we're going to identify interested and qualified members to join the community garden committee. And then we'll be having regular committee meetings, whereby people are going to meet and be represented by their committee members. And then we're going to coordinate gardening activities through those community garden committees. And then we are going to make decisions on different operations in each and every of those gardens through the community garden committees. And then we're going to engage community members in decision-making through their garden committee members. Next slide. Then finally, I'm going to hand over to my colleague, Elisha, to continue and explain the timeline of the Growth Thrive project. Thank you.
Thank you, Zotile. As she said, I'm Elisha McKenzie, and I'll be discussing our timeline for the Growth Thrive project. So our timeline will be over a period of 24 months. The first 1 to 3 months will consist of planning and preparation to include a community needs assessment, securing locations and the permissions for the community gardens, testing the soil and preparing the land for cultivation, and constructing a budget and plans for fundraising. The next 4 to 8 months will consist of recruitment and outreach by launching our marketing campaign, exploring partnerships with local businesses, and holding information sessions and workshops. Next slide. Months 7 through 8 will consist of establishing formal partnerships with the businesses. Also, a memorandum of understanding will be developed. Months 9 through 12 will consist of implementation of the community gardens through planning and planting with community members, tracking the usage of the gardens, and hosting of monthly gardening workshops and events. Next slide. Months 13 through 18 will bring in community engagement through harvesting, evaluation, and review of the project. The monthly workshops will continue. We will start the process of developing a selection process for the community garden committee. And finally, months 19 through 24 will focus on establishing the Community Garden Committee. An election process will take place for the potential committee members. Once selected, orientation and training will take place for those members, and finally handover of decision-making to the selected community members. Next slide. And I'll be discussing our applicable theories of change. Our theories of change include the health belief model, the trans-theoretical model, and diffusion of innovation theory. The health belief model will emphasize individuals' perceptions of health issues, benefits of behavioral change, and barriers to adoption of the Growth Thrive program. The trans-theoretical model will address aligning program objectives with behavior change stages by providing resources and support to community members at various readiness levels. And the diffusion of innovation theory will introduce and promote sustainable gardening through partnerships with local businesses, workshops, and events to facilitate community adoption. And I'll now be passing you along to my colleague, Ruth Azagula, to discuss staffing and personnel.
Sorry, Ruth, your voice is very soft, please.
Can you hear me now?
Better, yes.
Okay. We will be having registered dietitian nutritionists, RDNs, marketing professional, business logistics and negotiations professional, experienced farmers and growers, supply chain manager, and environmental nutrition, health, public health educators. For our RDNs, they will provide guidance on the selection of crops and gardening practices that promote health and wellness based on their education and knowledge. Marketing professionals will be in charge of utilizing various channels to reach target audiences and enhance the visibility of the kindergarten initiative. Our business logistics and negotiations professional will be in charge of the logistics of the program, including scheduling, budgeting, and the procurement. Our experienced farmers will assist in sourcing land and materials needed to establish the community garden. Our supply chain manager will be in charge of optimizing logistics, so they'll be working very closely with our business logistics manager to streamline processes and minimize operational costs. They'll also be working very closely with our partnerships with grocery stores. And then lastly, our public health educators will be in charge of leading the workshops and educational sessions that will be developed by our RDNs. So they'll work closely with our RDNs to teach the workshops and educational sessions. Next, please. Next up, we have our budget. We have a total budget of $120,000. And within this budget, we will have $42,000 allotted for our site preparation and infrastructure, $10,000 for land acquisition and lease, $15,000 for site preparation, $70,000 for fencing and security, $10,000 allotted for water supply and irrigation. Next up, we'll have $33,000 for garden setup and design, $15,000 for the garden beds to build raised beds and soil and compost, $5,000 for paths and walkways so it can still be aesthetically pleasing and our team members can walk through the garden, $10,000 for structures and storage, $3,000 for seating and shade within the garden for benches, picnic tables, or shaded areas. Seeds, tools, and equipment will be budgeted for $15,000, $5,000 to garden seeds and tools, $7,000 to power tools and machinery, and then $3,000 for composting, fertilizers, insecticides, and waste management. We'll have $10,000 for education and outreach, $5,000 for workshops and trainings for hosting these educational sessions, hiring instructors, providing materials, $2,000 for outreach and marketing, $3,000 for community events. We have $18,000 allotted for staffing and volunteer coordination, $15,000 for staff salaries and stipends, $2,000 for coordinating the volunteers, and then $1,000 for our mentorship programs. And then lastly, we have $13,000 for administrative and contingency funds, $5,000 for insurance and permits, liability insurance, and necessary permits for the garden, $3,000 for administrative costs, and then $5,000 contingency fund. Next, please. Next, we're going to evaluate our program. So to evaluate our process, we are going to be doing client satisfaction surveys to measure community awareness, interest, and satisfaction, which will then lead us to tracking participation levels, pre and post outreach campaigns, then leading us to monitoring the number of engagements of local businesses and the value of donations. And then lastly, we'll measure committee diversity and contributions to decision-making by conducting demographic analysis for diversity regarding gender, race, age, background, creed, expertise. Next slide, please. For our outcome evaluation, we'll focus on conducting site observations to evaluate the produce, make sure they're fresh and improve, and make sure that it's actually improving the accessibility impacts, the usability of the kindergarten. Next, we'll develop a skills inventory to see how much our community is actually learning from our mentors, their mentors, the farmers, RDMs, our public health educators, monitor the progression of their specific gardening skills among them. Evaluate decision-making efficiency by tracking the time taken to address issues or implement changes within the kindergarten. Looking at further on what's working and what's not working, and adjust as necessary. Lastly, we'll be conducting surveys, once again, with community members to assess changes in food security status. Next slide, please. I'll be passing it on to my colleague, Prakash. Thank you.
Thank you, Ruth. Now I'm going to talk about dissemination of Growth Drive. Next slide, please. Before the program, communication channels, we would utilize social media, local newspapers, and flyers for program awareness, for informational sessions, introducing program goals, gathering inputs, and recruiting participants and volunteers. For partnerships, we would establish and collaborate with local organizations, schools, churches, and businesses for support and promotion. Next slide, please. During the program, communication, providing updates on activities and events through newsletters, social media, and in meetings, workshops and events, engaging participants with hands-on learning opportunities, and promoting sustainable gardening practices. Outreach strategy, utilizing door-to-door outreach, community events, and word-of-mouth promotion to reach community members. Next slide, please. After the program, sharing success, communicating program results, and success stories through presentations, reports, newsletters, and local media. Leadership transition, supporting the garden community to take over leadership with training and guidance for sustainability. Next slide, please. Growth Drive program outcomes. 1, increase community engagement in gardening activities. 2, improve accessibility to resources for community garden members. 3, enhance gardening skills and knowledge among community members. 4, improved organization and decision-making processes regarding the community garden. 5, decrease the prevalence of food insecurity and increase access to fresh produce. Next slide, please. Thank you. If you have any questions, please feel free to ask. My colleagues and I would answer it. Thank you.
Thank you so much. This is great. This is great. Hey, look, go to your chat and let us give it out for group 1, right? Let us give it out for group 1. I'm looking for my reactions. I'm giving them my clap. What are you giving to them? Do they deserve your clap or your kudos? Dorothy says a clap. Let's see, Gabriel gives them a clap, 2 hands, you know. What else? What else can we give to them? Okay, I have questions, a lot of questions. Question number 1. So this group is asking for $120,000 to implement Growth Thrive in Forest County in Mississippi. So I looked up quickly about this county just to find out what do we have. So this county is 55% of the population, overall population of the county is about 78,000 people and is the county headquarters for Harriger, County. 55% are white, 36% are Black, 3.3%, 4.1% or 4.2% are Hispanic or Latino, and then 1% Asian, 0.04% Pacific Islanders, and then 3.3% other or mixed race. So you can see that this issue around food insecurity is not limited to brown and Black communities. You can see that this is a predominantly white county, and there is high food insecurity in that area. So that tells you that it knows no race, it knows no ethnic group. So I had, and that made it very exciting for me to ask you a question. You are asking for $120,000 to implement a program over 24 months. My first question to you, Group 1, is how will you sustain the program after the grants funds are finished? That's number one question. Number two question is, how are you even going to get the land? I did not see in the presentation how you are going to acquire the land to do the farming. So whichever one you want to start, maybe you can start with, how will you get the land to do the farming in Forest County?
Good morning, everyone. So the first thing we will do is conduct an assessment, because depend on our research, there is different level of soil quality. So we will design flyers and meetings to ask for people who can donate funds or can donate us and land to make our community garden. This is an option. A second option is by participating with the local businesses there, we can collect some funds that could increase our the funds that already we have to buy a land.
Okay, so land purchase, that's more complicated in the United States, right? Purchasing land is complicated, and the grant funding will not allow you to purchase land. So 120,000, I'm not sure you're going to use 120,000 to purchase land in Forest County, Mississippi. So I need a little bit more there. We're going to give you $120,000, and that is to implement the program. That is not to do needs assessment. You're not going to use grant money to do needs assessment to identify the area. How are you going to acquire land, and how are you going to sustain the program at the end of the grant funding? Yes, Ruth, you were trying to, please adjust your microphones when you are speaking. We need to be able to hear you, and we need to have people on YouTube or Facebook also hear you. Go ahead, Ruth.
So there's no like adjusting, but I will try to speak up. So a few ideas for acquiring land, because I was thinking about this, is land contract. We could have communication with the land or with the county of Mississippi, with the state of Mississippi and local businesses and consider a land contract. That's one option. Option number two, land giveaways for people who have land but then they've gone into foreclosure. We can look for land giveaways. There's the Homestead Act of 1862 that still exists today, in which properties that are distressed or properties that are not being paid for can be given away. Through government websites, local, state, and federal governments do land giveaways, so you can scour through there and try to find something and buy it through there. It's cheaper that way, or it can also just be given away. Nonprofit organizations, also there are nonprofit organizations that have land trust alliance. That could also be a way that we can communicate with them. They can use outlets, just getting the word out there, just see if there's anybody who has land that they want to sell, acre, 2 acres, or partner with them to use that land for this community. And those are just a few ideas that.
Great. Okay. How will you sustain the program? We give you $120,000, right? The funder gives you $120,000. You implement the program for 24 months, 2 years. What happens? The grant funds are finished. What happens? So is that going to be the end of Grow Thrive, or is Grow Thrive going to continue? How will you sustain this program? Because now you have excited the community members towards community gardening, and the funds you have are finished. How will you sustain the program? I see Brown says we need to move to the other group, but I need to really hear sustainability for you.
We are right now. I have this fundraising, making sure that we're fundraising throughout the 2 years so that we can build sustainability and also partnerships with local businesses who could sponsor us to keep us going. And then on a yearly, what do you call it when you fundraise? Yes, that's, yeah,
Zotile, how would you sustain the program after the grants funds runs out? The grants funds is limited. It's given to you 2 years. That's it, done.
Yes. Okay. We can continue sustaining the program in the following manner. First of all, isn't it we are having community gardens, and those community gardens are producing produce. That particular produce, we can actually sell them in partnership with the strategic partnerships that we would have formed. Remember, we are partnering with different organizations and businesses, supermarkets, producers of agricultural products. Secondly, we can actually be in partnership with other businesses that do canned foods, or should I say produce canned foods. We can actually sell them those produce and ask them to or implement a program whereby we can have some of the produce being canned and bottled for reselling in different counties as well. That will bring us a lot of cash as well. And we can actually have the drying of these vegetables and other products, because it's also a long-term food. We can keep the food for a longer period through selling dried produce. So it's another way of gaining more cash after the grant fund has run out. So I think that is sustainable.
Very good, Zotile, right?
Yes.
Most public health people, one of the problems that public health practitioners like all of us here have is we always want to depend on grant funding. Grant funding is soft money. It comes and goes. So even before you start any program, you need to begin thinking how you are going to sustain it. And Zotile was on point. That is what we call social enterprise component of public health program implementation. How can you support the enterprise? How can you raise money? By selling some part of the product. So where you, and that is really, really important in global health, because you have a community where people cannot afford the food, but you need to sustain the program. So you can do 70-30, or you can do 80-20, where 20% of the food you give to families who are unable to afford it, and then 80% of the food you can sell for individuals who can afford to pay. You know, remember, this is organic food, and then you can really go to other countries to sell it. So really important in public health to think about sustainability beyond the grant funding. But all around, Group 1, congratulations for identifying a program that addresses a problem that exists in a predominant white community, white county in the United States of America. Thank you so much. Join me and let us congratulate them in a round of applause, please. All right, group number 2. Are you guys ready? Tell me we are ready. Tell me we are ready in the chat, group 2. I'm reading. I can't see group 2 say we are ready. They're not ready? Group 2, oh my God, they said they are not ready, so we can. Okay, Fabian said we are ready. Gabriel said we are ready. Okay, group 2. All right, we are ready. We are here waiting for you guys. Let us know what you're going to do.
Yes. Good morning, everyone. We are group 2, And my colleagues and I are here to present our program, the Nigerian Diabetes Awareness Care Project, and DAC. My name is Benedict Kialanda. I am the Project Director of Technology and Platforms. Rosemary Issa Obale is the Project Director. Zaidi is the Director of Strategic Partnerships. Katie Wells is the Director of Outreach and Communications. Gabriel Kogo is the Director of Monitoring and Evaluation. And Fabienne Noidike is the Clinical Director. Next slide, please. All right. So first, we wanted to highlight the global issue of increasing type 2 diabetes prevalence due to economic growth and urbanization, which poses a major healthcare challenges worldwide. This rise in diabetes affects individuals' daily functioning and overall quality of life, which contribute to a higher burden of illness and an increase in premature death. So our program, the NDAC, specially focuses on urban population in Abuja, Nigeria, where we found the incidence of diabetes being particularly high. The program aims to offer education and raise awareness about diabetes. It will cover many aspects such as identifying risk factors, implementing prevention strategies, and understanding management practices to effectively address and mitigate the impact of diabetes in these communities. Next slide, please. All right, so here's a study of diabetes by age group in Abuja, Nigeria. And we have observed that the age from 35 to 44 years has the highest number of people with diabetes. However, we aim to rank, our target is from 16 to 65 years old, because we wanted to start earlier, spreading awareness and preventing measures instead of waiting until it gets worse, and that might be very challenging to lower the number of cases. Next slide, please. So we wanted to highlight the critical need for intervention to address the rising burden of diabetes. And we think without effective measures, the consequences will include a higher healthcare cost, will also reduce productivity and lower quality of life for affected individuals. So the NDAC program is designed to address these issues by educating and equipping the urban population of Nigeria with the knowledge and tools needed to prevent and manage diabetes. And this proactive approach aims to mitigate the negative impact of diabetes on both individual and in the community overall. Next slide. So now I'll pass it on to my colleague Rosemary for the goals and objectives of our program.
Thank you, Benedict. So as clearly stated that diabetes is a growing health concern in Nigeria, particularly in the urban area, and here we're focusing on Abuja. So limited access to testing often delay diagnosis and treatments, leading to complication. And additionally, many lack the knowledge about healthy habits that can prevent or control diabetes. Next slide, please. So to address this problem, the main aim, our main goal, is to reduce the prevalence of diabetes in urban Nigeria of age 16 to 65 years by increasing awareness, testing, knowledge of healthy habits, and adoption of those habits. This program using the SMARTY model would implement two key objectives. One of the objectives we'll be implementing will make it easier for people to get tested by organizing free diabetes screening camps. We'll organize camps in July, September, and November, aiming to screen 300 people. Next slide, please. The second objective would target increase in knowledge of healthy habits through educational pamphlets. And this pamphlet will contain evidence-based information on healthy habits for diabetes prevention and control. And this information will be tailored to the urban lifestyle. So how do we aim to, next slide please, how do we aim to implement these objectives? So there will be three free camps that will be organized. And these camps each aim to screen 100 people each. So in total, we'll be screening 300 people. We'll be partnering with healthcare providers for testing, supplies, qualified personnel, and also lab services where necessary. For us to choose a site, we'll be choosing an high traffic area with limited healthcare access. And for this project to be well executed, there will be a pre-camp awareness whereby we'll print out flyers, posters, and also radio announcements where people have access to listen to on a daily basis to promote these camps in different languages, in the local language of that community. Next slide, please. To execute on camp, on site, we would have trained personnel who would conduct the blood glucose test. And because of the sensitivity of this project, we'll provide professional counselors that would help provide initial counseling based on the results of the blood test. So we would encourage participants who are with elevated results to seek further medical evaluation at the nearest healthcare centers. We'll be able to track the number of people screened and diagnosed, and we'll also be able to analyze feedbacks and explore long-term sustainability with local health departments around. So objective 2, we aim to, the education pamphlet will contain evidence-based information on healthy habits for diabetic prevention and control. And as I said earlier, it will be tailored to urban lifestyle. And this pamphlet will be well designed in a way that it will be able to explain this healthy habits. That means it will have appealing visuals, and also it will be designed in local languages for better communication and for better comprehension. We'll distribute this pamphlet by partnering with community organizations, with schools, and also would have volunteers who would help us distribute this pamphlet and also be able to answer basic questions that are being thrown out. We aim to track this pamphlet distribution and conduct survey to assess the reach and impact of this information. And by doing this, we would also develop a digital version which would help with sustainability of this information, and also would it help us explore partnership for a long-term printing and distribution. So I'll pass it on to my colleague Saida to give you what we expect the outcome of this project. Thank you.
Right, thank you. So the Nigerian Diabetes Awareness and Care Project has specific program outcomes. With our goals, we aim to achieve measurable outcomes and deliver our objectives to impact the lives of the participants and the community. Our objectives are set to a more realistic time-bound standard, which allows for clarity and feasibility. Our goal is to reduce diabetes prevalence in urban areas in Nigeria, measuring to increase screening and early diagnostics, which include 3 screening camps to be implemented in the months of July, September, and November of 2024. Our other goal is to improve the management of diabetes, having monthly workshops dedicated to educating individuals within 5 urban communities. And last but not least, promoting healthy habits by distributing 10,000 pamphlets within 6 months. We'll move on to the next slide, which includes our target population. Our target population includes the urban residents in Abuja. The ages we're looking to focus on around 16 up until 65 years of age. And the communities we aim to focus are underserved communities. But the impact we aim to achieve is to reach about 300 individuals within 1 year from the start of the program, focusing on low income and marginalized groups. I'm going to pass it on to Kelly to elaborate more on partnerships and staffing plans. Thank you.
Hi. Well, with the partnerships, we aim to help implement the support with the NDAC. Partnerships and alliances will be formed with the International Diabetes Federation, the World Health Organization Foundation, and the Institute for Spirituality and Health, and the Health E Foundation. The International Diabetes Federation is a global nonprofit organization that serves as the voice of the diabetes community worldwide, as it has over 200 national associations in 161 countries and territories. Their capacity complements our program because they work with many international partners to improve people at risk and living with diabetes. The Institute of Spirituality and Health is an interfaith-based independent nonprofit that believes there is a link between mankind's spirituality and health, which is the key to human wellness. They have formed many collaborative relationships with different belief systems and cultures. The organization aims to improve human well-being by discovering the relationship between health and spirituality. Their capacity complements our program because they can support the African groups and populations in diverse languages and cultures. And the World Health Organization Foundation is an international nonprofit operating under the United Nations agency that links countries, partners, and individuals to health promotion to keep the world safe and serve those who are susceptible so that all people worldwide can reach the highest health levels. Their capacity complements our program because they work with 194 member states throughout 6 regions and 150 locations. And so collaboration is the heart of their work. The World Health Organization supports governments, civil international organizations, foundations, advocate researchers, and healthcare professionals in civil society, so they can help us mobilize communities and other partners in sub-Saharan Africa to advance the health and security of all people who are at risk or living with diabetes in Nigeria. And the Health E Foundation was founded in the Netherlands because it believes healthcare workers need access to accurate state-of-the-art information. In Nigeria, some healthcare professionals need more essential health resources. This organization provides health educational programs in various formats, such as diabetes prevention and management, to teach communities and medical staff. Their capacity complements our program because they can help us increase diabetes awareness by utilizing innovative technology at a distance, online learning, and mobile health. People can learn at their own pace, anytime, anywhere, and even in remote and isolated regions. Our staffing plan, the project director, as mentioned earlier, is Rosemary, and you see her credentials. The program director will contribute to achieving the program's goals and outcomes by overseeing planning, implementation, and dissemination within the organization, defining its vision, scope, objectives, and milestones, ensuring that they align with the business strategy and goals. And our clinical director is Fabian, and you see his credentials. The program director will contribute to achieving the program's goals and outcomes by supervising clinical operations, managing staff, ensuring that the program adheres to regulatory compliance, and driving leadership support and improvement to ensure its success. And we have the Director of Outreach and Communications, which is me, Kelly. These are my credentials. The Director of Outreach and Communications will contribute to achieving the program's goals and outcomes by communicating with stakeholders, including community members and partners, to engage in dialogue and ensure its goals and objectives and mission, strategies, and values and commitments reflect their needs and requirements. And the Director of Strategic Partnerships and Communications is Saida, and you see her credentials there. Director of Strategic Partnerships will contribute to achieving the program's goals and outcomes by instituting collaborative partnerships that will reinforce stakeholder relationships and lead to business growth by deploying system-wide planning. And I will pass it on to Gabriel for the evaluation plan and dissemination.
Thank you, Kelly. Thank you and welcome to the evaluation and dissemination segment of this project, which is very key. In the evaluation, we'll be looking to measure the desired change in the goals and objectives that were enumerated by my colleague, Rosemary. Now, these goals and objectives are numerous, but will not be capturing, will not be, for the purpose of space, will not be putting everything on this presentation. But it's very important to say that it's not just going to be about numbers. We're going to be looking at the qualitative aspects first, before we talk about the data. Now, in the qualitative aspect, we want to look at the process, of the projects and from the planning stage to the camps, the 3 camps. And we'll first of all want to look at the monitor the criteria for the equipment, the quality of equipment that we'll be using, okay, and see if they meet the criteria for the states in which we are carrying out these projects. And also the personnel. I know we've said that we're going to focus and make sure that they are qualified personnel, but we're also going to be looking at the qualifications of these people. This will be documented as part of our evaluation reports. And then we'll be looking to capture the change in knowledge, which is very key, knowledge and understanding of diabetes and other symptoms and risk factors and even prevention strategies. We'll be doing this by using pre and post survey questionnaires. We'll also be measuring the quality of the program through focus group discussions and feedbacks at every stage of the project. And also, we'll be looking at the behavioral change. This is after the project now. We'll be going back to the community to capture the changes in the behavior in the community towards their attitudes towards diabetes prevention and even management. Now let's go to the numbers. The outcome indicators and the data description will be, first of all, classifying each and every participant that will be involved. All the 300 people that will be involved will be classifying them according to their demographics, male, females, others, age, race, educational status, life choice, family history of diabetes and other underlying chronic illnesses. We also use the opportunity of having them at that point to measure some key indicators that are related, like a body mass index, waist circumference, blood pressure. And also we'll be looking at the number of participants that actually attended and also monitor the number of participants that carried through to the end of the project. And we'll be comparing and there will be the indicators that were enumerated earlier will also be carefully outlined, and then they would be compared at every camp. Remember, we talked about having three camps in July, September, and November. So every camp, all this data I'm talking about is going to be applicable for every camp, and then they'll be compared at the end of the project. And then we'll be looking at the program reach and engagement. We'll be measuring that as well. And then finally, on evaluation, we'll be looking at how sustainable the sustainability goals. That is post-project, how this program has been successfully embedded into the healthcare system of the state in which we're carrying out this project. Now, a very key part of this project will be the dissemination. And the results and finding that we have, which will be huge, will be used as tools in our arsenals of change. And the disseminations will be targeted at two levels. The first level will be, first of all, to our funders. And it will be a high-powered meeting that will be organized through the Ministry of Health. And the reason why we're organizing this through the Ministry of Health is to foster ownership of the project for sustainability after the project. So this meeting will be organized with them, and it will be targeting the key stakeholders, the policymakers and influencers like the religious leaders and churches and the mosques and community leaders as well. And also the Minister of Health and other high-power delegates will be involved in that meeting. And that meeting will also be used as an opportunity to network and for the purpose of sustainability. Then the second level of dissemination will be to the participants themselves who are engaged. They would like to know the outcome of the project they participated in. And we'll be doing this using community radio jingles, in the local community town hall meetings to disseminate these results. We're using town criers. We'll be collaborating with community influencers to help disseminate this information. And also the dissemination of flyers also would also contain some of these results and further information. And just to mention that the flyers will not just be will be in the local languages as well. Okay, now all these things I've mentioned is going to take a lot of money, and that takes us to the next part of this project, which is the finance. And for that, I'll be handing over to my colleague Fabian.
Thank you very much, Gabriel. Thank you very much. For the budget,
looks like we're having problem with Fabian's connection. Fabian, are you still there? All right. Who else in the group can take this presentation while Fabian figures out his connection? Gabriel, can you continue?
Get it up.
Benedict.
Okay, so still on the budget, we'll be looking at the cost breakdown into planning and partnerships. First of all, the categories, and then the description, and then the estimated cost. Note that cost you're saying is in Nigerian naira, not US dollars. So that's going to be corrected. So it's the money, the dollar sign, just neglect it. It's in naira. And then also the justification for spending that amount. However, if you note on the final cost, it's not in Nigerian naira, it's in dollars. Okay. So the planning and partnership, yeah, the final cost is the grand total there. Okay, we'll come back to that. Let's go back to the top. So for the planning and partnership, the site selection, we'll be looking at 43,000, about 4,377 naira. And this is to identify areas with high population and limited healthcare. And then we have earmarked for the 10,000 flyers and posters for awareness and also for translation to local languages. As I said earlier, we've enumerated 785 naira. And then for the camp execution setup and supplies, we have
okay, thank you, Gabriel, for standing in. All right, okay. For the camp execution for setup and supplies, we have $598, and this entails decks and testing stations and counseling areas. We have waste disposal for good medical waste disposal to avoid cross-contamination. We have $224.47. We have evaluation and sustainability, which tracks the screening numbers, $598. We have content development. This involves collaborating with healthcare professionals and also ensure evidence-based content. We have $224 for that. Design and translation, graphic designing, creating visually appealing pamphlets, $336. We have monitoring and evaluation, $134 to monitor distribution through the partner organizations. Sustainability for digital pamphlets, we did the offline and now we're also doing online. That's $157. Next slide. We also have, for the distribution channels, partnering with the community organizations, $411. Monitoring and evaluation to monitor thoroughly the distribution through partner organizations, $134. We also have sustainability again, and travel and transportation. We have $1,870. And for the project management and administration, which includes staffing, office supply, and insurance, we have $5,349. Contingency for unexpected costs, we have $1,122, and in total, we'll be spending $15,854. Next slide. So we'll be passing to my colleague Benedict to take on the timeline.
All right, so here's a timeline that has the key deadline for the completion of our project. So we're going to highlight the first year and what we aim to achieve. So for the first month, we want to hire personnel and train them, especially those who will conduct testing, registration, and counseling. And then we'll use the first month to also develop the tools that we'll need, flyers, social media posters, and also materials that we will need for evaluation, like surveys and all. Next slide. All right, so the next phase will be our implementation. Like we said earlier, for the first year, well, for each year, the total year is 2 years, but we just highlighted the first year, so you have an idea. So we will do the screening and testing in July and space it out September and then November. Like I answered earlier, because we don't want to run out of money while we're doing the testing, and we know we also need enough personnel. That's why we're going to space it out. And then within the 6 months, we will start distributing pamphlets in different churches and schools. We'll just leave it out to 6 months to give us time to properly develop all the materials that we'll need, and then we'll keep the awareness going on until the end of the year. And the last phase will be our evaluation. First, we will collect survey that will be throughout the year, and then the analysis of the data, the reports and dissemination that will be every 6 months in the mid-year and the end of the year. Next slide. So to conclude our project, the NDAC aims to reduce the prevalence of diabetes in urban Nigeria among individuals aged 16 to 65 through increasing awareness, testing, and promoting healthy habits. We utilize the SMART model for clear, measurable, and objectives, and we also seek partnership with local health department and NGO for long-term sustainability. We want to thank you for carefully listening to our group, and we are open to any questions. Thank you.
Great work. Let us thank Group 2 for a wonderful project using our reaction buttons. Thumbs up, I'm giving them. All right, as you can see from the chat, this project has elicited a lot of questions, and I think that is really expected. Whenever you do a project and it touches Nigeria, because Nigeria has the largest population in Africa, you really let people wake up. So, Federal Capital Territory of Abuja is almost like an independent capital city for the country. And it has, depending on data that you are reading, they say the population is more than 6 million people. And because it's an independent capital territory, it is not a state, just like Washington, D.C. is. So people come from different parts of the country to reside in Abuja. And that is why the questions we are seeing there are coming in. So first of all, I'm going to go through the question, which area in Abuja will be chosen for this program? And I want the group to be specific, right? Because this is what we are calling about geographic expertise. Remember, we talked about you in global health, somebody could come to you and say, what is your topical expertise? You say epidemiology, HIV/AIDS, maternal and child health. Then the next question they could ask you is, do you have any geographic expertise? There, they are trying to talk about, are you an expert in Middle East and North Africa? Are you an expert in Sub-Saharan Africa? Are you an expert in Asia? So this group is trying to become a Nigeria Sub-Saharan Africa expert. And that's why the questions are coming here. So in Abuja, which area are you going to focus for this program? And I want you to be as brief as you can because we have many questions that we have to fill.
Okay, so the area that we're focusing on is an area called Nyanya. I don't know if any of you have lived in Abuja, but I have a working experience there. It's urban. It's very urban, but much of the poorer population lives there. So it's kind of like maybe a 10 minutes drive from the center. And it's a very dense population, dense area.
Okay, so it's going to be in Nyanya. So there is the FCT, the metropolitan area, right? The metropolitan area of Abuja. Then as you go outskirts, there is Karu, there is Suleja, and then you are going out. All those areas are still called Abuja, but we know between the metropolitan Abuja is an area where you have the zones, right? You have the Maitama, you have the zones, the life camp, and so on. So so that means this program is changing because you told us it's urban area, but it looks like you are going a little bit more in the outskirts, which is not the urban areas.
Now, the population that work in the urban, they live, majority of them live in Karo and Nyanya. So it's still the same urban population we're testing. It's just that the location of where they live now is a bit outskirts, but it's the same people that go into the main center to work. Just like you mentioned, that Washington is more like a working area. So we're capturing the same people in the urban area, but living outside.
Okay, very good. So there is an observation here for you that the budget is unrealistic, and I do agree. Abuja is a very expensive place, and it's unclear to me how you are allocating your costs. You know, how you're allocating costs to personnel, how you're allocating costs to, to program, and it's a very, very expensive place to live. So that observation for you, so I'm not sure, Fabian, whether 21 is that $21,000 or 21 million naira. The budget should be in dollars and no more than $200, $200,000. Okay. The next question, someone had asked why you were having consecutive months in your screening, and Rosemary answered, or Benedict answered that because that is to conserve resources. Can you speak a little bit more why you are skipping months in your screening programming?
Yeah, I think I said we will need, like we are training some personnel to do the glucose test and screening, all that. And we are working in Africa, so lower middle income country. So we think we want to make sure we conserve money in personnel. We probably might have people going in and out. So if we do it consecutively, we might have days where we don't do screening. So that can impact our population, and people may not take it serious or may not come and drop or come to screening. So we want to space it out while keeping awareness and making sure that we have enough people for screening.
Thank you. Yes, somebody's agreeing with me. Good. Okay, so one last question that's really, really important. Everybody who is in this program completed an ethics training. In this project, you have proposed to have 300 people in your sample. And this is a capital city that has over 6 million people, depending on where the source is. So how will you ethically limit the number of people coming to the program to 300 when, remember, you're going to have a social media, you're going to have flyers in different languages, you're going to invite people to participate in this program, and 12,000 people shows up. How are you going to ethically limit the number of people to 300?
I can elaborate on that. So the point is to understand the higher risk population. So individuals who are of higher risk has family history of and getting the diabetes and have unhealthy lifestyles. We're limiting and going more narrow down to people who the marginalized and vulnerable groups that we're focusing on.
Saida, the question is, You said 300 people are going to be in your program. You said you are going to advertise the program, right? You are going to put it in social media. Once you put it in social media, 15,000 people are going to see it, right? If you boost it, maybe 1 million people are going to see it. And you say we're going to do this in Nyanya, like Dr. Gabriel said. And then in the morning of the program, 20,000 people show up. How are you going to ethically limit to 300 people? And this question, because it's an ethics question, I'm actually expanding answer to anybody, any group, any suggestion, because this is really a key thing that will happen in public health. And I want to make sure everybody participates. So if you have solutions, we're going to begin with group 2, then we can expand it. So take it up, group 2. What will be your strategy to ethically limit participation to 300 people?
Can I speak a bit about that?
Yes, go ahead.
Now, looking at that scenario, 20,000 people attend the morning of the screening. We'll first encourage people who can afford it to have the test, go and have the test. They will benefit from the information. Remember, it's not just testing. There's going to be information dissemination as well. So everybody will benefit. However, because of our funding, what we have to test is just 300 people. So we'll encourage people to have testing. There are other outlets that you can easily test, and it's affordable, like pharmacies, even chemists. I don't know if you know what chemists are. They're not like they're like a lower version of pharmaceutical, stores that sell medication. So they have these testing kits, and they'll be able to do some of these tests. However, if people cannot afford, we will try to include them in that number of 300.
Thank you. Other thoughts, other strategies?
I think they should design like a program requirement that lets people know that they need to meet a certain criteria to qualify for the program. And that's what I came up with.
So you are hitting at something, Vikash. So first of all is to acknowledge the ethical dilemma that this group is going to be in. And this is actually exactly what will happen. Once people see flyer about diabetes screening, they're going to show up. So the first stage for you is to acknowledge internally and then plan on what you are going to do. One way here will be to say that the program is going to begin exactly like Dr. Kogo said, with education for everybody. That way, ethically, everybody gets the program based on the educational component, on the awareness component, on the risk profiling, that everybody who shows up in the program gets that. Then the next stage you do is to talk about who are the people that have the highest risk, right? And then that helps you in your flowchart to reduce to the next stage of people who have the highest risk. Within that group, you can begin to limit to 300 people based on a transparent model that you say you're going to move on to the next stage of the program because of X, Y, Z. And that gives you a tool that you're actually going to use in raising money and returning to the funders to be able to tell them that you have more need that you could address in the program. So we can talk more a little bit about ethical issues in community-based programming. But this is really something for you to have. And I hear now somebody is telling me to move to the next project. So on that note, I think group 2, thank you so much. Let us give them a rounding applause again with our reaction button. All right, good. Okay, so group number 3, are you guys ready?
Yes, we're ready.
Take it away.
Hi, everyone. My name is Asila Ferguson. I'm the program director for Birth LA, which is Bridging Information, Reproductive Training and Health, Louisiana. And here are my team members who are going to introduce themselves.
Good afternoon, everybody. My name is Ariel Swilly, and I serve as Director of Technology and Platforms.
Good afternoon, everyone. I'm Darte Lamptey, and I'm serving as Director of Strategic Planning.
Good afternoon, everyone. I'm Poonam Bajracharya, and I will be the program manager for our program.
Tina, you're muted.
Good afternoon, everybody. My name is Augustina Oha. I will be serving as Director of Monitoring and Evaluation. Thank you. Here I will be stating the problem statement. Maternal mortality is a crucial public health concern in New Orleans, with rates significantly higher than the national average and those of other similar large and wealthy cities. This issue is particularly severe among Black women in New Orleans, Louisiana, with them who face increased risk of pregnancy-related complications and deaths. Maternal mortality in Louisiana was 69.9 per 100,000 live births, compared with 26.6 of their white counterparts. Now I will hand it over to Acelia to help us with the goals for the project.
Our program has two goals. The first goal is to educate Black pregnant women about prenatal care and patient self-advocacy. And the second goal is to collaborate with healthcare providers to reduce the impacts of systemic racism. Our objectives are, by the end of the program, increase prenatal knowledge by 50% by having participants score a 70% or higher on the healthcare scenarios quiz. At the end of the program, increase confidence in patients' health advocacy by 30%. And by the end of the program, have a decrease in adverse healthcare interactions by 25% as measured by surveys.
Thank you, Asila. I'm going to discuss our project implementation plan, which is basically an overview of how we intend to roll out the program. So we're going to begin by identifying our members' roles and their respective tasks, identifying our population, which is Black, pregnant, and less than 1 year postpartum women in New Orleans, Louisiana, aged 15 to 49. Then we're going to identify our initiative, which is Birth LA. It's going to be a community and evidence-based resource center for Black women and birthing people. Our approach to this is going to be using the social cognitive theory. And then we're going to identify our project services and partnerships, which includes many health education workshops and forums, which involves prenatal nutrition, postpartum recovery, support services, including mental health, doula services, lactation consultants, etc. Our main partners would be Oceanar Health, which is Louisiana's top nonprofit healthcare system. We have the Birthmark Doula Collective, faith-based organizations such as Walking with Moms in Need, working with the New Orleans Health Department and Louisiana's Department of Health's LA Moms Initiative. Our ideal timeline would be 2 months. And now I'm going to pass it to Poonam to discuss our approach.
Thank you, Darty. So the theory we selected for our Birth LA program is the social cognitive theory. It is an interpersonal level theory developed by Albert Bandura, and it emphasizes the dynamic interaction between people themselves, the personal factors, their behavior, as well as their environments. The social cognitive theory postulates that change in behavior is brought about and maintained by a dynamic interaction between an individual and his environment. And I will pass it back to Darty.
Thank you. So as mentioned before, our desired timeline would be 2 months. So we're going to take about 6 days, which includes gathering our requirements, which includes identifying and holding discussions with key stakeholders and our partners, and also creating a customer acceptance criteria. Next, we would be developing a schedule, which approximately would be about 30 days, which includes determining our timeline, listing and tasking priorities, identifying and implementing security measures such as ambulance services nearest hospitals, volunteer services, and EMS. Then we would do designing and building our project solution, which includes finding a site location, determining program daily schedules, possible website, social media, and issues that may arise, including project monitoring, which would be about 5 to 10 days, which would be setting up a customer database, on-site installation. Then you have training for our health educators, and then which will take about 10 days. And then we're going to be doing a soft launch, which will be about for 1 day.
Thank you, Darty. So these are some of the outcomes that we expect at the end of our program, and something that we can measure. So we hope to improve self-efficacy among all the participants, and this would be measured by 50% of the participants scoring at least 70% or higher on the healthcare scenarios quiz that we will be administering. We will also expect a 30% increase among all participants in self-reported confidence in their ability to advocate for themselves. The second outcome that we're measuring is improved collective efficacy, which is there'll be decrease in self-reported discriminatory healthcare encounters, and we expect a 25% decrease among all participants. Next slide, please. So the overall goal of our program is to reduce maternal mortality rate, but this will not be directly measured during the program course, and instead we'll be measuring a more proximal outcomes such as knowledge of prenatal care and self-efficacy in patient advocacy in the program. Thank you, and then I'll pass it on to Tina.
Thank you.
So the target population is Black, pregnant, and postpartum women residing in New Orleans, Louisiana, age 15 to 49. Louisiana women are plagued by high unemployment rates, high poverty levels, and low levels of educational attainment. This target population, particularly Black women, often experiences the most severe traumas related to racism and gender discrimination compared to any other minority group in the United States. New Orleans is considered a health professional village area, which is a geographic area in need of more primary care, dental, and mental health care providers. The city is classified as a medically underserved population and is being monitored to focus resources towards changing this designation. Over a third of the state's parishes do not have an obstetrician gynecologist. This state has a very high maternal mortality rate of 39.0 deaths per 100,000 live births. The Black U.S. maternal mortality rate has improved recently, but is still significantly higher than that of white, Asian, and Hispanic women.
So now to introduce the roles of our team. Asila Ferguson is our program director. She holds a BS from Georgia State University in biological sciences and is currently an MPH student at Walden University. As program director, she will oversee program implementation, partnerships, formulation of budget, and community engagement. Poonam B graduated with the MBBS degree from Kathmandu University and is currently enrolled at George Washington University pursuing her MPH. She will serve as program manager, providing analytical support and recommendation in budget, program performance, and program policy. Dorothy Lamptey currently serves as the Director of Strategic Planning. She will be tasked with streamlining the goals and objectives of this project, conducting data analysis, and identifying potential risks and challenges that may impact the implementation and/or sustainability of this program. She holds a BA from Pennsylvania State University and is currently pursuing her MPH. I serve as Director of Technology and Platforms. I hold a BA from the University of Miami and will be tasked with developing a technology plan for our education materials and creating proposals for digital platforms to better engage the community. And finally, Dr. Augustina Oha holds a PhD in public health from Walden University, specializing in community health education and promotion. She will serve as the Director of Monitoring and Evaluation, overseeing data collection and analysis to assess program effectiveness and providing strategic insights for decision-making. She also ensures compliance with organizational standards and manages the monitoring and evaluation team. And I'll pass it on to Tina to discuss our monitoring and evaluation plan.
Thank you. Monitoring and evaluation. We are going to use the following are the tools we are going to utilize to monitor and evaluate the program. One of the tools include survey and questionnaires. Structured survey and questionnaires will be used to collect quantitative data, baseline, and follow-ups information on participants' demographics, health behaviors, and program satisfaction. Interview and focus group. In-depth interviews and focus group will be conducted with participants, mentors, and healthcare providers to gather qualitative insight into this into their experiences and perception of the program. Health record reviews. Data collection, monitor for process evaluation will include attendance records, training completion certificates, section logs, and participants' feedback survey. Regular reviews meeting with the program staff will also be conducted to identify any challenges in implementation and to make necessary adjustments. Health record will also be reviewed to track key health indicators such as prenatal visits, mortality rate decrease. Data collection method for outcome evaluation will also include pre and post intervention surveys, health record reviews, and interview with participants and healthcare providers. The program will also track key health indicators through collection with the local health departments and clinics. Program record documentations. Detailed record of program activity, attendance, and resource distribution will be maintained to monitor implementation liability and identify areas for improvement. Next slide. Anticipated findings include decrease in parental care utilization, increase in parental care utilization, increase in health care utilization, positive lifestyle modifications, decrease in maternal mortality rates, increase in health literacy, increase in resource awareness, and participants' satisfaction. Reporting the findings. Summary of the results. The findings from the monitoring and evaluation activities will be documented in comprehensive reports that summarizes the program's progress, impact, and decrease in the maternal mortality rate in New Orleans. These records will be shared with the program's stakeholders, including community partners and participants. Key components of the evaluation report will include recommendations, which will include suggestions for program improvement. Dissemination. Finding will be shared with stakeholders and community through publications and social media. Now, I will hand it to Poonam to talk to us about the budget.
Thank you, Tina. For our program, we will be requesting a budget of $120,000. It has been shown that community-based approaches can improve maternal health outcomes and experiences, while at the same time also reducing costs. Based on our research, the cost of the community-based intervention in a small community for about 1,200 participants will be approximately $120,000, and hence we're requesting the budget. Next slide, please. And this is what our potential budget will look like. The compensation for personnel will be about $47,000. We would also be allocating for rent for a workshop or seminar space. Next item will be education and training supplies. We expect that there'll be some consultant fees for an OBGYN and doula that will come and train our participants. Program promotions will be allocated $2,000. And other indirect costs will be 25% of the total budget, about $30,000. Thank you. I will pass it on to Tina.
Thank you. In conclusion, we are going to verify or evaluate the program impact. The outcome of the project will be recorded in relation to reducing the rate of maternal mortality in this population. Further direction, potential for scaling and replication in the light of all the identified changes, the challenges, barriers, and need to decrease maternal mortality in New Orleans, Louisiana. More research and projects are encouraged. Final note, we are emphasizing the importance of community-based support in decreasing maternal mortality rate in New Orleans, Louisiana. Thank you. Now we'll be ready for any questions.
Thank you so much, Group 3. This is a project that is very, very close to my heart, right? I have written in several places that the Black maternal mortality rate in the United States is an international disgrace. And the reason why I said that is when you compare the United States with other developed countries and you look at the data on Black maternal mortality, you will be ashamed. And I'm hoping by the program that you are designing and hopefully the program that you are going to implement, that you all leave this program really more aware of this huge disparity that is taking the lives of many Black women where they are trying to bring another life. So please, these and other issues should be really critical in your minds as you practice in public health. So I had the first question for this group. Why was Louisiana selected, right? What are the basis of the selection? What is the data that you have, comparative data? And Asila was trying to answer that. Can you tell us why out of the 50 states and the District of Columbia in the United States, you selected Louisiana?
Yeah, so as I mentioned in the chat, one of the reasons why we picked Louisiana is because of the region of the United States that it's part of. So the Southeast region of the United States has the highest maternal mortality rates. So we picked Louisiana because it had one of the highest maternal mortality rates in the US. And then we picked New Orleans specifically because it has a high Black population.
Any other questions for this group? Lynn says, like the inclusion of further direction and scalability. You like it. Okay, okay. Any other questions? So my other question for this group is, what do you see or what do you foresee as barriers to successful implementation of this program?
One of the barriers I see for this high rate of mortality in Louisiana is, first of all, there are many factors that influence this. First, socioeconomic status. Secondly, their healthcare workers, sometimes they're not friendly to the pregnant women, so they run from them. Another one is, I will say, like, I don't know how to put it. Sometimes the pregnant women, some of them use substance abuse or alcohol or something, so they run from the healthcare provider so that they're not there for their habits.
Thank you so much. Thank you so much, Tina, for that. So something to think about when you're implementing a program. What are some of the things that will stop you from succeeding, right? I see trying to target the entire New Orleans with $200,000. For me, that seems a little bit far-fetched.
Yes.
So some specificity as to where and how would have been very, very helpful for me to know, to say this is too many people, the population and the specific changes that you are anticipating to see in that population would be very helpful. But this is great. Join me and let us use the reaction button and give group 3 our congratulations and kudos. Keep it coming. I know you guys are really tired. So Gabriel, can you just give us something to stretch, for people to stretch, something like 1 minute for us to stretch? Everybody here is already exhausted while we wait for the Ghana team. Gabriel, please help us. I know you're at work, but help us.
We're not going to run today. Okay. I hope you can see me.
Yeah.
All right. So stretch out. We'll do the aeroplane. I call it the aeroplane. That's my own terminology. The aeroplane stretch. Okay. And that's hands out, first of all, as far and then as back as possible. And then chest out. Then before head out, because if you do head out first, you might fall. You tiptoe. That's tiptoe. You can see me. And pull your bum in, roll your buttocks in as if you're trying to open up your waist as wide as possible. And then you take your head back. Careful because you might fall. Stretch for like a few seconds as hard as you can. And then you come back. A simple stretch. Remember, this move uses up to over 95% of muscles in your body. So it's a very good stretch.
Thank you so much. You see, we have everything in PH360. We have everything. An in-house gym instructor who is also a doctor. Thank you so much, Gabriel. This is great. Okay.
Thank you.
We are ready for group number 4. You save the last for the best. So I'm really excited, and I'm hoping that all our guests, all the members here are going to listen in and get ready for their question. Group number 4.
Can you guys see my screen?
Yes.
Okay, so welcome. I just want to say thank you all for joining us to listen to all of these great presentations. I loved hearing all of your presentations as well. So our program is called Advancing Resources for Traditional Birth Attendants for Infant Survival and Maternal Empowerment, otherwise known as ARISE Ghana. And this is through the Global Health and Educations Project. We know we're familiar with them, but they're a nonprofit that aims to eliminate health and education disparities. And my name is Rahina. I am the Director of Strategic Partnerships. And these are my teammates, if they would like to introduce themselves.
Good afternoon, everyone. My name is Kayode Oluyemi, and on this project, I'm the Director of Outreach and Communication.
My name is Amos Ajang. I'm the director of I'm the project director.
Hello, everyone. My name is Dr. Emeka Adibe. I am the clinical director.
Good evening, everyone. I'm Dr. Lins Grant Oyeye, and I'm the Director of Monitoring and Evaluation.
So this is just an overview of our program. I'm going to be going over the introduction, which is essentially our executive summary. Then we'll be going over our problem statement, program descriptions, as well as our goals and objectives, the outcomes, the expected outcomes of our program, the target population, and our partnerships, as well as our program management, evaluation, and our dissemination and outreach, budget, as well as our conclusion. So I will be going over our introduction. So the RISE Network program aims to reduce maternal and infant mortality in Douambra, Ghana. We will be doing this by empowering TBAs, which are known as traditional birth attendants, through a comprehensive training, through creating and advanced communication tools through our RISE Network app, as well as creating a robust emergency response system. And my colleague Emeka will be going over our problem statement.
Thank you, Raina. Globally, approximately 25% of births occur with the assistance of traditional birth attendants, otherwise known as TBAs. In Ghana, despite efforts to increase skilled attendants at birth, over 30% of deliveries still rely on TBAs, contributing to increase in maternal and infant mortality rates. Unskilled TBAs are unable to recognize high-risk pregnancies and complications, which contributes to increased maternal and infant mortality rate, which is actually why we are going into this program to educate our TBAs and also take them through complications and which pregnancies are high risk. Next slide. This is actually a comparison of the problem, comparing global statistics with Ghana statistics. If you look at this slide, you discover that maternal mortality globally in 2021 is about 158.8 deaths per 100,000 live births, as compared to Ghana, where we have 263 per 100,000 live births. Also, approximately 287,000 women actually died due to pregnancy and childbirth complications, which equals roughly about 800 women dying every day during pregnancy and childbirth. Infant mortality globally is 17 deaths per 1,000 live births in 2022, as compared with what we have in Ghana, 32.6 per 1,000 live births. Ghana's neonatal mortality rate is 22.8 deaths per 1,000 live births. At this point, I will pass it on to Amos, who will be talking to us more about the program description and goals.
Our program again is Arise Ghana, and the aim of this project is to decrease maternal and infant mortality in Ghana, starting with Domibra, and this will be done through empowering traditional birth attendants through a comprehensive training program, the launch of the Arise Network app for communication and collaboration, and the establishment of a community volunteer network for emergency response. Next. Now, the program description. Our approach is firstly to empower traditional birth attendants through training, the launch of the Arise Network app for communication, and the establishment of community volunteer network for emergency response. The key activities would include, firstly, establishing curriculum which is a culturally tailored curriculum to train the TBAs on responding to emergencies, and then actually doing the TBA training program, launching the Arise Network app, and also establishing the network of community volunteers. And with this, we are going to be addressing the health issues by increasing the TBA proficiency in recognizing birth complication. Yeah, we give them the ability to recognize birth complications and also seek timely intervention for clinical expertise. The curriculum would be developed in collaboration with the local authority for relevance and effectiveness. We are going to seek engagement, firstly with the TBAs, and also engaging them through the enrollment process and with partnership with the community leaders. We are going to foster support and participation from the TBAs to ensure effectiveness of the project. Next slide. Next slide. So the Arise Network overview. The Arise Network app has as purpose, firstly, to enhance communication and collaboration among the TBAs, clinical experts, and the community volunteers. The key this app shall be available in the Apple Store and the Android Store, and the key functionalities of this app shall be, firstly, to connect the TBAs with clinicians and transporters during birth complications. The app automatically assigns the closest volunteer when there is a complication. It enables a real-time tracking and monitoring of transporters' movements for visibility to clinicians and the TBA. And it will have the ability to send alert notification. It will help in maintaining communication between the transporters, the clinician, and the TBAs, as during the transportation process. And it would allow the clinicians to provide timely instructions during patients' transport. The app will also have the capability of recording essential information for clinical management. And with this, it will ensure that patients confidentiality is maintained and there's efficient healthcare delivery. The Arise Network will also have as part the establishment of a supervisory structure where a group of TBAs will respond to clinicians, and this would help in supervision and training. And with this, this app is going to be revolutionary as it's going to optimize. It's going to optimize the assignment of the transporters, enabling real-time tracking, enabling continuous communication with a secure data, and it's going to improve timely and effective intervention for pregnant women in need. And overall, it's going to lead to a decrease in maternal and infant mortality. Next slide. As Dr. Romy would say, we are requesting for $170,000, as you will see later on, for this program. And when that is done, what next? how do we sustain this program? So our objective remains to ensure that the app remains functional continuously day and night. Our first strategy is, first of all, to equip the TBAs and volunteers with solar power banks. That is when there's no electricity, and then conduct a training on how to use the app. Secondly, how do we ensure continuous funding of the program? First, we are going to establish partnership with the network through network sponsorship, the mobile network suppliers. We have the MTN and the Orange, and we are going to highlight mutual benefits with these suppliers. Secondly, fundraising events. We are going to organize charity walks, concerts, and health fair, and to showcase the benefits of this program to the masses who would, of course, appreciate what this is doing to the community. And through that, we are going to raise funds. We are going to also exploit advertising, getting revenues through in-app advertisement by partnership with businesses for in-app advertisement, having different levels of and premium features or other services. First and lastly, we are going to engage legislators and policymakers for funding. They're going to see our data and to see how successful this program is, and through that, we hope to get funding to continue this program. I will now hand over to my colleague Rahina to continue.
Thank you, Emma. So I will be going over the outcomes. Ideally, by the end of the 6-month program, we would want 90% of the TBAs in the region to be both proficient in utilizing the Arise Network app, as well as have substantial medical knowledge about pregnancy and birthing complications. We also would want improved collaboration between the communities, physicians, as well as our partners, to develop seamless transportation services and delivery of health services to improve outcomes for pregnant women. And ideally within we would measure this yearly, but within 5 years after the implementation of the first intervention, that maternal mortality rate will be reduced by 30% within Doambra. And then our target population. So as we mentioned, our pilot program location will be in Doambra, Ghana. Struggling a little with the pronunciation. This is a small town located in the Nkoranza North District of Ghana. This with a total population of 56,000 and about 56,500. And 78.4% of this population, so 44,300 people, live in a rural area. Just to highlight the fact that, being in a rural area limits access to health services. Additionally, a substantial percent of the population, 41% of the population, do live in poverty. So they're a huge portion of the people that live in this area within this region both are impoverished as well as live in a rural area. So that severely limits their access to health services. So it's important that we find ways, which is part of the reason why they rely on traditional birth attendants, because that's honestly one of the only resources that a lot of places have. And then on to the next slide. So this is just a percentage of people who utilize having deliveries are essentially assisted by non-skilled or traditional birth attendants. So in the northern region of Ghana, about 63% of deliveries, so that's the majority, are assisted by non-skilled attendants, while in the central and upper western regions, it's approximately 39% and 38.6% occur at home, and it's assisted by traditional birth attendants and relatives. And our target population is specifically training the traditional birth attendants in Doambra, Ghana, in order to effectively like improve their skill sets and their knowledge too, because they are a vital resource within the community. So it's important that we improve their skill sets. And then our partnerships. So one of them will be the Christian Health Association of Ghana. This is they partner with 374 health facilities and health training institutions within remote villages, and they have affiliations with local TBAs. And one of the hospitals, the St. John's Hospital, is a local hospital nearby that is under this association. So we will be able to partner with the clinicians there so that they can oversee, they can be the overseeing clinicians for the network. And we will also utilize their affiliations with TBAs in order to recruit TBAs within the program. And then another partnership that we will have is the OKB Hope Foundation. So this is a nationwide, within Ghana, a healthcare organization that aims to make healthcare accessible in rural areas. And they do this by providing mobile health clinics to different rural areas, as well as health education and transportation services. So we will collaborate with them to train our community volunteers, as well as to help with the like transportation process aspect of our training, of our program. And the last organization is our PATH. So this is actually a global organization, but they do have different programs within it. So one of them is a maternal and child health program. And this one actually partners with the Ghana Health Services, which oversee the hospitals within Ghana. And they train and equip caregivers with necessary tools and knowledge to recognize and prevent labor and delivery complications. So the educators, ideally the educators from PATH, will work with community leaders to engage and train the TBAs. And then my colleague Lynn will be going over the program management.
Thank you very much, Rahina. So for the program management, we have together a team of competent and dedicated professionals. Amos Ayong, who is a doctoral candidate, is the project of public health, is a project director, and he will oversee the implementation and the general execution of the project. Kayode Oluyemi, also a doctoral candidate, is a director of outreach and communication, who would support the team and stakeholders in ensuring that from the design to implementation to post-implementation, that the communication strategy is up to par. And we have Rahina, whom you've just heard from. Rahina is an MPH candidate, the Director of Strategic Partnerships, and Rahina would continue to direct the team around stakeholders and fostering the goal through a shared vision. Next slide, please. Additionally, we have Emeka Adibe, who owns an MBBS degree and is an MPH candidate. He's a clinical director overseeing the clinical aspect of the project to ensure that they meet guidelines such as the WHO guidelines, and also taking into consideration the best interests of the clients and women in the community and babies as well. Finally, we have Lynn Grantoyeye, myself with an MBBS, I'm a doctoral student of strategic leadership, and I'm the director of monitoring and evaluation. My main role would be to support the team in ensuring that from design to implementation and post-implementation that we are keeping tabs on ensuring that the process goes smoothly, ethically, and that also that the outcome is in the best interest of the women and their babies. Next slide, please. So in terms of the evaluation and monitoring, we're going to use both qualitative and quantitative measures to look at the outcomes, look at the processes, and also try to ensure that some balancing measures are there with the ultimate goal of a successful program, improvement in maternal and decreasing maternal and infant mortality rates in the community. So some of the methods that we would use would include surveys, pre and post implementation, ensuring that we engage stakeholders for feedback through focus groups, interviews, and also especially look in addition to the other aspects of the program to ensure that the transportation aspect also is monitored to ensure that we are meeting the goals, especially timely and efficient transportation of the women from when the app is activated to delivery in the hospital. So all stakeholders will be involved in ensuring that we collect adequate data and monitor the process. Next slide, please. Yeah, so we will, in terms of the training aspect, we're going to track attendance and to ensure that the TBs are available to attend the training and benefit from the training. And then we'll collect feedback as well to ensure that the training package is accessible in terms of language, in terms of understanding for participants. And also from the drivers. So the ultimate goal of evaluation and monitoring for us would be to ensure that we have not just a program that is robust in terms of theory, but a program that actually meets the need of the target population, which is in this case TBAs in Jamaica, because sometimes with programs, designers might run into the problem of having a very good program, but how effective is a program if it does not connect with the people that the program is for? So the Arise Ghana team is dedicated to ensuring a program that works for the people. Thank you. And now I'm going to hand over to my colleague, Emeka, who is going to talk about dissemination.
Thank you, Lind. I think I'm in charge of the dissemination. Thank you. So to effectively disseminate the content of the Arise Network program and to engage with the community of the MEBRA, we are going to be employing a multifaceted approach, an approach that captures both the locals as well as the partnership, the essential partnership that have been mentioned by both Amos and my other colleagues. So we are going to be organizing local events, workshops, and seminars in the community centers and also in the religious organizations that we have mentioned earlier on. And the aim is to provide direct information and to engage the community through these workshops and seminars. So, and the partnership that we are going to establish, we are going to be exploring the partners, the stakeholders, at these events. And since they already have existing relationship with the TBAs, we're going to be exploring those relationships to recruit the TBAs. My colleagues have talked about the Christian Health Association of Ghana. They have hospitals almost everywhere, and one of their hospitals is the St. John's Hospital in Domebra that we are going to be utilizing. So we are going to have the collaboration with them. Next slide, please. So also, we are going to be disseminating information through social media. We're going to be having awareness programs, and information that educate people about the Arise Network on Facebook, Twitter, Instagram, TikTok. We're going to be using all those avenues to distribute information on social platforms for people to be involved of the creation of the program, and to let people know that the TBAs are no longer people they cannot trust. They can trust them because now they have partnership with clinicians, they have partnership with transporters in the communities. Their response time is now going to increase, and they are now able to recognize birth complications, and they are able to make decisions based on the trainings that they have received. So this is going to help the community to patronize the TBAs with confidence. We are also going to be sharing information through brochures and flyers and posters that we are going to be distributing in public spaces like libraries, clinics, and in their grocery stores. And this material that we are going to be distributing will be made both in English and their local language to cater for the diverse population of Domebra. Now, next slide, please. All right, so now I'm going to be calling on my colleague Emeka, who is going to be talking about the budget.
Thank you, Kayode. So I'll be talking about the budget, just like what Kayode has outlined. This cost money, and we have been able to break down the budget here into training costs, technology and tools implementation, supplies, travel, and stipends. So for the training costs, we've outlined that $32,000 will be needed for hotel and all for training. And our main goal here is to have at least 2 or 3 trainings before the end of this program. Then workshops that was also mentioned by Kayode, that will be organizing in the with the community leaders, religious leaders, and also market leaders, will cost about $22,000. Publications like flyers, brochures, posters, and also this will also include social media posting, like in Twitter, in TikTok. $30,000 has been budgeted. Then training cost total came up to $84,000. Then for the technology, where we talked about the Arise Network app development, we intend actually ensuring that the Arise Network app is not only for activating the app alone. There are other features that will be included, and that we budgeted about $5,000 for that. Then we also budgeted for 10 phones for TBAs who do not have phones. Phones will be provided to them. Those that have phones, we encourage them to use their phone. However, if at any point in time they start having problem with their phone, then we'll ensure that phone is provided. We budgeted 6,600 for this solar power panel. In most of the rural areas, electricity is a great challenge. So we're going to be providing solar power panels for them. We budgeted for 30 panels, which we budgeted $15,000 for. Total of technology and implementation, we budgeted $26,600. Then supply, which will include laptop. We intend having somebody that will help us to coordinate all these programs here in Ghana, which we call Ghana Project Manager, that will be going to see one-on-one, visit the TBS, also visit the other providers in this network to ensure everything is going on well. So laptop for the Ghana person with all other features that will be installed in the laptop, with printer that will also be provided. That came up to budgeted $10,000 for that. Then travel allowances for the project manager who will be traveling a lot. So some of these areas to see the TBS and also to visit the hospitals, also visit that we are going to be networking with. We budgeted $10,000 for that. Then for the Ghana project, we also budgeted stipend for the Ghana project manager, just to make sure things are going on very well. Total, we came up to $24,000 for stipend for the manager. Then total direct costs came up to $154,600. Then indirect cost, which we made about 10% of the total direct cost, came out to about $15,460. Total that we budgeted for this project is $170,060. Thank you. At this point, I'll hand over to Rahina, who will tell us more about, who will give us the concluding part of this project.
Thank you, Emeka. So the conclusion is the Rise Ghana program is a comprehensive approach to reducing maternal and infant mortality rate. And we will be doing this by empowering and educating TBAs, enhancing communication and collaboration within the community, between community partners, the community, and clinicians, as well as ensuring rapid emergency response. And so with the support of our partners, our stakeholders, and the community, this project will significantly improve health outcomes for women and infants in Doambra, Ghana. Thank you all. You guys have any questions?
Fantastic. Thank you so much, Group 4. This is great. This is great. Let's show them some love. This is nice. Really, really nice. Well done. Well done. Fantastic. Okay, so we have a couple questions for you. I have a question. And at the end of the presentation, we're going to do a poll. So for each group, we are a community. We want to see how ready each of these projects are for implementation. And we're going to have 3 scales, Likert scale, if you remember in your evaluation. So 1 being ready, not ready, 2 being ready with modification, and 3 being ready, which means if that program is picked up, that program can actually be implemented. Good comment here. Say, I like how this program promotes the autonomy of TBAs in the target community by respecting cultural norms while still ensuring they are informed about MCH risks. This is really a very difficult project because this project is bringing 2 communities that are not traditionally used to working together. And I think the group has very carefully crafted a program that will engage all the individuals, both skilled and unskilled practitioners. So really, really commend you for this project. All right, so questions. Who has questions? All right, Vikash asks, group number 4, what is the length of the training program for TBAs? Will they be confident at the end of the program to be able to handle high-risk delivery situations? How are you going to assess this? Good question by Vikash. Group 4.
Thank you, Vikash. So we plan to have this program fully implemented within 6 months. That's our timeline for the program. And during that period of time, we have training sessions for the TBA to upskill them in identifying pregnancy-related complications, and to also be comfortable using the Arise Network app, and the system that we are created. So at the end of the 6 months, we expect that they will be confident in themselves. We are expecting that about 90% of the TBAs in the program will have increased their skills and will be able to respond appropriately to any pregnancy related situation.
So
Very good.
I wanted to add something to it. Let's not be confused. We are not training them to handle or to handle birth complications. They are just recognizing it and then connecting with a clinician to handle it. So I think the 6 months time frame is feasible for them to learn that and be able to recognize complications. Thank you.
Thank you for that clarification. What do you think? What might be some barriers to successfully implementing this program?
I think. Oh, sorry. Somebody.
Okay, go ahead, Rahina.
So I think one was actually mentioned in the chat was like mistrust between like community TBAs and like hospitals. That's a huge issue here in the US as well. So I can see that being something that would be a barrier. I think one way would be by like collaborating with the St. John's Hospital and the Christian Association and creating like community events to foster that relationship, because that is a barrier. It's like mistrust and resistance. I also think like something Lynn just put in the chat is like resistance also from skilled professionals. So like they may not agree with some of the methods or like methodologies of like the traditional like birth attendants. And so that's something to also keep in mind, is that we have to find that middle ground between them both so that they're able to effectively work together.
Thank you, follow on to that question, Kayo, the take on this one too. How would you document this agreement between TBAs and the group? How would you, because you can say things orally, what are some of the strategies to really ensure that this is documented somewhere?
All right. So one of the things that we planned is during the recruitment and the training process, the hub that we connect the TBA, the clinicians, and the community transporters we have like tracking system. The TBAs will be able to enter some information that will be feasible to the clinicians. They can some background information they can rely on to be to collaborate well. So through the app, we'll be able to track how many people have used the program, what the success rate has been. And just as Emeka said, we're going to have a local program manager that is going to be part of the the Arise Ghana network, who will be responsible also to collect data and information about the success of the program.
Any questions? Any other questions from the team, from the group?
Yeah, one thing I wanted to say about the first question you asked about potential hindrance that we might come across in the implementation of the program is the fact that Domebra is a rural area. Most of the TBAs are elderly people who may not be technology savvy. So we are going to be training them on how to use the app. Some of them may not even have a phone. So we are going to be providing them phones. We are going to be training them on how to use it. And we are going to be having follow-ups with them.
One other, I think the first question again, in terms of the hindrance or the barrier which we also try to also foresee is the financial situation. For most of them, we'll be asking, how do they pay for the services that will be provided at the facility where they are being transported to? This might be one of the other barriers why most of them don't want to be transferred to go to any other facility, because they are thinking more, who pays for that? And we've actually discussed about this in-depthly in our team. Part of the workshop and the seminar is to encourage them as much as possible. Their life matters a lot. And by the involvement of the other team that we are going to be networking with, the Christian Association, they will also be of help in terms of paying some of the bills in case if they do not pay most of the bill by the time they get to these hospitals or clinic where they will be attended to.
All right. Okay. Language barriers. How did you guys really arrive at your budget, the costs? How did you arrive at the cost of the mobile application, the cost that you're going to pay project staff? How did you arrive at that?
Okay. Yeah, I actually went, I think, online and looked at some of the cost of some of these provision. And I also looked at the rate in terms of, because definitely dollar will not be spent in terms of when the services will be used in Ghana. There will be change to their local currency there. And case for the project manager, for example, the stipend where we mentioned 24,000, we're looking at roughly about an estimate of $2,000 per month. Aside the traveling allowance, we have already made budget for traveling allowance, which will cover expenses for the project manager that will be traveling once in a while to visit this TBA. Then for the hub, we also look at it not only paying for the hub that really matters, it is so what will be imputed in the hub. We were able to look at other features that will be included in terms of some data that will be input by the TBAs for the clinicians to see. Then also few other features that are more like customer friendly for the people who will be using the volunteer transporter or the volunteer drivers. Also, we're also able to also look at other features in terms of how will the doctor be able to see, okay, if they are picked up from one TBA centers, how will they be tracked? We thought about, okay, could we be able to collaborate or building something into the hub that can also monitor, that can also track their movement. So most of these figures, some of them, we were able to get them from online to see what is the cost even for the panel, and we're able to just put them together and say, okay, rough estimate, this is what it might cost us.
Any other questions for group 4? I think this is a great program. I see a lot of potentials in this program. One of the things I just want you guys to consider. Okay, there is a question. Thank you so much, Rosemary. Said there is a question on YouTube live for group 3. Brown, can you pull that question? I want to make sure that we are answering questions for people joining us virtually. Thank you so much, Rosemary. Or you can paste the question here, or you can unmute and ask, please.
Okay, so the question says, is there a percentage you aim with the program in assisting and mitigating of childbirth deaths?
So is this for group 4 or group 3? Group 3?
I'm sorry, can you repeat the question if it's for group 3? I didn't hear.
Is there a percentage you aim with the program in assisting and mitigating of childbirth death?
The medicating of, I didn't hear the end. If you're able to type it in the chat, that would be better.
Okay.
Please.
All right. So for group 4, one thing to consider will be how portable, and maybe for everybody, how portable is this program? Assuming we decide to implement this program in, maybe we take it to Zotile in Zimbabwe, or we take it to Kenya, or we take it to Uganda. How would that adaptation work? Any thoughts? Group 4, beyond group 4.
So actually, even in choosing the title of the program, Arise, we took into consideration portability. That was why if we see, it was called Arise Ghana, meaning it could be Arise Nigeria, it could be Arise Zimbabwe, starting from that. So the only thing that we would need to tweak would be looking at the peculiarities of any areas we wish to implement, and then tweaking. For example, the partners would be different, but from the beginning, we considered portability.
Thank you. That makes a lot of sense. That makes a lot of sense. So the question for group 3 is there a percentage that your program is aiming to accomplish in terms of the number of infant mortality? Is there a particular percentage target for your program if successfully implemented?
If we can reduce the mortality by 25%, we have done a lot. We have achieved something. But we would like to see it go much further. But this is not what we are going to cut right away. It's gradually we got to get to that 50%.
Yeah, and I answered that question in the chat. If you scroll up in the chat, I wrote our objectives, and it has all the percentages of increase and decreases for like confidence and self-advocacy, prenatal care, education and knowledge. And then the third one is what was the third one? There's so many oh yeah, and then self-reported racial like bias or discriminatory healthcare encounters.
Great. Let's give group 4 another round of applause. Good job. Good job. Good job. Boom. Okay, so I just want us to try something as a community, including our guests who are watching online as well as YouTube and Facebook. We have, listened to 4 innovative programs. Project number 1 designed a program to address food insecurity in the United States. Project number 2, NDAC, designed a program to increase awareness and care for diabetes in Nigeria's Federal Capital Territory. And then project number 3 is called Birth Early, addresses maternal and infant mortality through education, awareness, and advocacy. And project number 4 looked at training for TBAs in Ghana, Rise Ghana, as a foundation for addressing maternal and infant mortality. So you can see really addressing key and specific problems, across the world. So maybe one thing we can do now is to pose a question to say, for group number 1, right? Group number 1, if you were to be the evaluator, and they have presented this project to you. You are in the team that is evaluating the program. How would you rate project number one? Would you rate number one that it is ready to be implemented, or ready to be implemented with modification, or not quite ready? So let me paste the scores here. I just want to have an idea of how, when you wear your evaluation hat, how would you evaluate each of the projects? So 1 means not ready, 2 means ready after modification, and 3 means what? Ready to go. So we're going to do it for project number 1, and that is food insecurity in the United States. I do want everybody to vote, recognizing that the people who are in that group will say, will always, most likely be biased. That's okay. Two, makes sense. 2, okay. Okay, mostly 2. Keep the numbers coming. 2, okay. That's fair. 2, 2. All right, okay. Project number 2 is NDAC, Nigeria Diabetes Awareness and Care Program, NDAC, right? How would you score project number 2? 1, not ready. 2, ready after modification. 3, ready to go. Two, 1. I saw 1. Okay. Yeah, 1, 2, 2. 2, okay. Predominantly 2. Predominantly number 2. And then project number 3 is BERT LA. BERT LA. BERT LA. How would you rate BERT LA? Number 1, not ready. Number 2, ready after mod. Number 3, ready to go. 2, 1, 3 here. 2, couple 3s. Couple 3s. That's interesting. Project number 3. Couple 3s. Please, when you are polling, make sure that you select all. I'm getting some people select, when you click the drop down to, you select meeting group chat. Don't select me, because when you select me, you're just sending it to me. All right. Okay. And finally, for project number 4, Arise Ghana. What do you think? 1, not ready. 2, ready after mod. 3, ready to go. Amos, you are biased. I know that. I already know that. So I'm factoring in 5 biased polls. And then when you do your correction, then you can get the closest. 3, couple 3s, couple 2s. I'm not voting. All right. You don't want to be biased, because we're going to catch you, right? I am not voting. All right. Okay. Project number 4. Predominantly 2, right? Okay, so this is really very helpful. Next time, I know this is a crude poll. Next time, Brown is going to look for polling feature in Zoom, or another polling that we can use to lay the polls side by side. But in general, I think most people think that these projects are ready to go after some modification, right? Some of the modification will be to clarify the problems addressed, some of the locality, geographic expertise, recognizing that this is a competition, and then articulating things around sustainability. How can you grow the program, using people there? But overall, I think these are very solid programs. I think for me, I think they're somewhere between 2 and 3, right? 2 and 3. So this is really great. I want to once again thank all of you for being really present, right? You joined the program and you are present in the program and you are really committed to seeing to the end of the program. So once again, I want to, on behalf of the faculty, congratulate you on your graduation from the program. It has been a fantastic opportunity having you in the course. I hope you will continue to be great ambassadors of this program. You know, tell your friends, tell your colleagues. You know, word of mouth remains, you know, the most important way of recommending any program. Our commitment is only one commitment. We want an increased number of minorities being able to get into public health so that you can support the transformation of all people's health. So I'm really glad, you know, we have some people here who are alumni of this program who have joined and who are carefully watching. These are people who fund programs. So we really want to thank every member of the family, friends, colleagues, collaborators who joined here today to thank and to congratulate each of our participants. You guys are great. Once we take a look at Google Classroom, we're going to make sure that you have captured and that you have completed all assignments, all project works, and then your certificates will be on the way. You know, when you get those certificates, I want to thank you. I want to really thank all of you. Yes, thank you so much, Kayode, for your wife, asking her to be here. Babatunde, thank you so much. All the other people here that I cannot, let me see, that I cannot personally thank. Blessing, Awe, thank you. Bukola, thank you. Yuwande, thank you for joining. Kehinde, thank you for joining. All of you, you know, this is a great day. You have supported your brother, your friend, your collaborator, your significant other to do this great program. If it was easy, everybody would be here, and it's not easy. So thank you so much. On that note, I want to wish you all well. Remember, your mission is to eliminate health disparities, no matter where you find yourself. Do not be a stranger. You belong to the GHEP PH360 family, and we believe that this is a lifelong relationship. See you guys. Have a wonderful day and congratulations.